differential diagnosis of lung cancer and anesthetic implications. It is presented by Shirley Mobley, Josue Morales, Deborah Angled, and Maria Villota. And this is our overview. The presentation will cover the examination of the lungs, lung diseases, information from evidence-based research, presentation of differential diagnosis of lung cancer, anesthetic implications of lung cancer, anesthetic implication of lung diseases, and we'll just show our summary and references. And for our lung assessment, we will go over the past medical surgical history, inspection, palpation, percussion, auscultation.
Examination of the chest and lungs. Inspect the chest and lungs. Inspect the chest from the front and back, noting 7 characteristics. Assess its size and shape. The anteroposterior diameter is usually less than the transverse diameter. Check for symmetry. Consider the thoracic landmarks and observe the costal angle, angle of the ribs, and intercostal spaces. Note the color of the skin, noting any cyanosis or pallor. Check for supernumerary nipples. Look for superficial venous patterns, which may signal a cardiovascular disease. Observe the prominence of the ribs as a clue to general nutrition. Assess respirations for 2 characteristics. Count the respiratory rate, which should be 12 to 20 breaths per minute. Note the pattern of respirations. The patient should breathe easily, regularly, and without distress. Chest expansion should be symmetrical bilaterally. Accurately describe abnormal respirations, such as tachypnea, bradypnea, hyperpnea, co-small breathing, and Cheyne-Stokes respiration. Observe chest wall movement during respiration, noting 3 characteristics. Inspect for symmetry. Check for use of accessory muscles, which should not occur. Look for bulging or retractions, which suggest abnormalities. Look for clues to respiratory problems in 4 peripheral areas. Inspect the lips and nails for cyanosis. Observe the lips for pursing. Check the fingers for clubbing. Inspect the ala nasi for flaring. Palpate the chest and lungs. Palpate the thoracic muscles and skeleton, feeling for pulsations, tender areas, bulges, depressions, masses, and unusual movement or positions. Expected findings are bilateral symmetry, some ribcage elasticity, relative inflexibility of the sternum and xiphoid, and a rigid thoracic spine. Unexpected findings include crepitus and pleural friction rub. Evaluate thoracic expansion by placing your fingers at the 10th rib and watching for them to diverge during quiet and deep breathing. Then face the patient and repeat this action with your thumbs along the costal margin and xiphoid process. Your thumbs should move symmetrically. Assess for tactile fremitus as the patient repeats numbers or words such as 99. Symmetrically palpate the front, back, and sides of the chest with a light, firm touch and feel for chest wall vibration when the patient speaks. Fremitus should be symmetrical. Examine the trachea. Percussion of the chest and lungs. Percuss the chest directly or indirectly, comparing sides in 3 areas. On the posterior chest, percuss with the patient's head bent forward and arms folded in front. On the lateral, percuss with the patient's arms raised. On the anterior, percuss with the patient in the same position. You should hear resonance over all lung areas. Measure diaphragmatic excursion. Have the patient inhale deeply and hold it. Percuss down the scapular line to the lower border where resonance changes to dullness. Mark that point with a pencil or tape. Have the patient take a few breaths, then exhale fully and hold it. Percuss up from the first point and mark where the tone changes from dullness to resonance. Be sure to tell the patient to start breathing. Repeat these actions on the other side. Last, measure the distance between the marks on each side. Excursion usually ranges from 3 to 6 centimeters. Auscultate the chest and lungs. Auscultate the chest with a stethoscope diaphragm, symmetrically moving from the apex to the base, comparing from side to side, and listening throughout inspiration and expiration. Tell the patient to breathe slowly and deeply through the mouth at a comfortable pace. To auscultate the anterior chest, ask the patient to sit erect with the shoulders back. Listen to the breath sounds, noting intensity, pitch, quality, and inspiratory and expiratory duration. Expect to hear 3 types of normal breath sounds. Vesicular sounds are low in pitch and intensity and occur over healthy lung tissue. Bronchovesicular sounds are moderate in pitch and intensity and are heard over the major bronchi. Bronchial sounds are the highest in pitch and intensity and should occur only over the trachea. Accurately describe any abnormal breath sounds, such as crackles, rhonchi, wheezes, a friction rub, a mediastinal crunch. Auscultate for vocal resonance as the patient repeats numbers or words. They normally sound muffled and indistinct. Abnormal findings are bronchophony, spoken words sound clearer and louder on auscultation, whispered pectoriloquy, even a whisper can be heard clearly, egophony, the voice intensity increases and has a nasal quality. Describe any cough according to its moisture, onset, frequency, regularity, pitch, loudness, postural influences, and quality. If coughing produces sputum, note its color, clarity, consistency, amount, timing, and the presence of blood or pus.
Lung diseases. You can see a list of lung diseases, and the list keeps going. Lung cancer can be divided into 2 categories. You have the non-small cell and the small cell. And the non-small cell can be subdivided into the squamous cells, adenocarcinoma, and large cells. And small cells can be small cells or carcinoids. Based on evidence research, lung cancer is broadly divided into small cell lung cancer and non-small cell lung cancer. It is important to note that 75 to 80% of these tumors are NSCLC. Also, smoking tobacco is responsible for approximately 90% of all lung cancers. Differential diagnosis of lung cancer. Lung cancer patients should be assessed for the 4 M's associated with malignancy: mass effects, metabolic abnormalities, metastasis, and medications. And this is a more detailed view of the 4 M's when you're doing a differential diagnosis of lung cancer. as we previously mentioned. Specific conditions associated with lung cancer. Pancoast tumors. Carcinomas of the superior circulus of the lung can invade and compress local structures, including the lower brachial plexus, subclavian, blood vessels, and stellate ganglion, causing Horner's syndrome and vertebrae. On this slide, you can actually see the Pancoast tumor. You can see it on the top left. Ethan Lambert myasthenic syndrome. This syndrome is frequently part of a paraneoplastic phenomenon, usually combined with small cell lung carcinoma. So the anesthetic considerations, patients should be carefully evaluated for the risk of postoperative respiratory failure. Sensitivity to depolarizing and non-depolarizing neuromuscular agents is usually increased. Carcinoid tumors. They will require the use of specific antagonist, octreotide or somatostatin.
Make sure everyone is there and on time. I'll be there in 5 minutes. Finish up my coffee. Okay.